revision, we have two challenges: a large bone defect and compromised bone stock, which can make reconstruction time-consuming and fixation challenging. The achievement of solid fixation of the implant is essential to allow early postoperative mobilization and improve the longevity. We need to improve our fixation. Stems are not enough. Small movement around the stem cause loosening and polyethylene wear particles. So how to slow this? Well, the solution was in 1976 with noise. You know, he used a step porous coated sleeve here. So he was a genius for us. And so and the porous coated metaphyseal sleeve was attached to the stem, and plus there was a mobile bearing. And Jones reported the results of this early cases, and they had no failure due to loosening. So that became the sleeve. And to fill the metaphysis with large contact area which allow bony integration, and it is attached to the stem with a cone morse. So this converts shear stress because of step sleeve into compressive load which favor bone remodeling. It fills the metaphyseal defect, and you crush the bone until you got your rotational stability. And also it encourages metaphyseal loading, so it reduces the need for long stem, engaging in the diaphyseal cortex and source of pain at the tip of the stem. So, revision femoral sleeve. Well, a lot of failures now, we are seeing this happen on the femur. And we can see, when you look in the coronal plane, valgus varus strain are controlled more or less by the stem. But in flexion, rotational torque is not controlled because of the stress of rotation around the stem, and that leads to loosening. So the sleeves control the femoral torque at 90 degrees. Why to consider mobile bearing in a revision? Well, it's interesting because it decreases the wear, it reduces the torque to constraining mechanism, and also it allows self-adjustment of the rotation of polyethylene on the tibia. Yesterday we saw one case revision just for malrotation of the tibia. So, well, mobile bearing has been used for more than 40 years. And I was using, well, this kind of stem, but afterwards, we had, in 2000, they gave us a sleeve around the LCS. Oh. Okay, so the distal femur we have seen is divided in three areas, but such as zonal classification provides a framework for preoperative planning, and it permits the understanding of where or how secure is fixation. So the steps are, as usual, tibial platform perpendicular, balance flexion gap, and it's very important if we can, because the ligament should be okay, and then extension gap. But preoperative planning is very important because the femur has a curve, and we must see where will be the stem. And we like to use now no stem or a shorter stem and sometimes we use only the sleeve. But when you have such a deformity, you should do an osteotomy, whatever the patient tells you. Well, tibial platform, it's easy. It's like usual. You broach for the stem, and then you sleeve, and then you cover, because the adjustment of the sleeve is free underneath. So you see, we can avoid overhang. The femur, well, that's tough. You need to work on the stem and then the sleeve for fixation. So what you have to choose the size of the stem according to the femoral size. You broach the stem, and then for the sleeve, the distal position of the sleeve with the size will give you your joint line level. So you will use distance between epicondyle joint line in extension. In extension, you very frequently need cuts because, and in flexion, you fix the rotation. So I think the technique is the same. You have to refer to the anterior cortex, and then you have to use, you have to broach. And well, you see here with this instrumentation, you can add this slide because it replaces the bony erosion, and with this you know where is your joint line. You have to broach for the sleeve until you get stability, and that's very important. And you must be precise with the sleeve and the joint line level. And then you have to test your flexion extension gap. And you have to be in contact, in extension with the sleeve. Well, now, we will see, metaphyseal sleeve is advantage because it provides short and long-term fixation to the articulation. It's fast. You should be able to get your joint line. And it's also interesting because we can use shorter diaphyseal stem if needed until the integration. So that was my first case in 2002. I had this patient, I opened it, I did my workup on infection before, it was not infected. And well, I have never seen such a big holes in 2002. So I closed. And there was no infection, so I went back and I did this noise. And you see here X-ray, and she was doing well, and she died 10 years later. Well, I think when you have this unit, well, we had problems before just with a stem. But if you have a stem and a sleeve, and it's like a LCS primary, the fixation happens around the cones. And it stays like this. Well, in zone 2, filling the defect, well, you can achieve with cement and bone graft, but that takes a lot of time. And we want to have shorter operations, so now we can use a sleeve. And now we tend to use a sleeve without stem, whenever it's possible. But sometimes it's in our zone 2 reconstruction, it's not fully secure, so we have to use in those 3 stem. A short stem cemented in good cancellous bone or longer stem, which needs to be in contact with the diaphyseal cortex. So when are the stems necessary with the sleeve? When you have bad bone, compromised bone or large defect, unable to get full immediate stability, you have to wait bone integration with the sleeve. And maybe when we use a hinge. So we will cement our stems when we have poor diaphyseal bone, large canal diameter, in patients where the canal geometry did not allow a reliable press fit for encymement. So that's allowed to use shorter stem, provide immediate fixation. When do we use uncemented stem? Well, when we had good diaphyseal bone, when we have good geometry to allow press fit, and longer and larger diameter stem. But we must think of possible hip procedures. The joint may be a problem. So that's a case which was infected, and we did 2-stage, and we fixed it, and we had a big defect in zone 2, so we use a stem, and we had good healing afterwards. So that's a case where we had a lot of femoral distal wear. And well, we use a stem, and we can see here, that's another case. And we see at 14 years old, it's very well integrated. And we see we were using at this stage the augment posteriorly. We were grafting, and it stayed. We show you this case yesterday, and a big bone defect, because it was backside wear. I did 50 of these. And revision, we use a stem, and
John V, can you hear us? Yeah, you can take 1 minute more.
Okay.
Yeah, thank you.
Okay, I will show you. Okay, that's a case of Dr. Nevin, osteomyelitis at 14 years old. He's 34 now. He replaced first the knee with a hinge, and then he did a total hip, and later he had a fracture, and it's become infected. And you see here, so he debrided, and he did a complete removal of the femur, and you see he reconstructed, and that's it. So sleeves in revision surgery, we use very, very often. It's more logical, it's faster, it gives a better primary fixation. While we think that with bearing, it's help and faster recovery and longevity, but we should not wait too long for revision. Thank you.